Hello, everyone. I am delighted to be able to speak with you today about one of my favorite topics, understanding respiratory comorbidity and supporting smooth transitions to PO feeding. I've been fortunate enough over my 25 years in the NICU to have worked with some wonderful respiratory therapists and neonatologists, and they've helped me understand the complexities of respiratory comorbidities and how their management, even early on, can impact future PO feeding for our little ones. So today we're going to take a look at how we can support infants with respiratory comorbidities from day of life 1 to succeed with their future transition to PO intake. First, some housekeeping. Financial disclosures. I receive, of course, an honorarium from Dr. Brown's Medical for teaching this course, and I don't have any non-financial disclosures. So our learning objectives for today are to relate at least one way respiratory comorbidity might impact the acquisition of oral feeding and the attainment of typical feeding milestones in preterm and full-term infants. Determine at least 2 appropriate strategies to improve short-term and long-term feeding outcomes for preterm infants affected by respiratory comorbidity, and differentiate one habilitative intervention to support feeding outcomes that can be initiated on an infant's first day of life. So let's dive into the respiratory system. So it's vital that we have a good understanding of how the respiratory system is designed and how it develops. Both are key components to knowing how to best support the preterm infant in navigating breathing and eating. Mechanically, the respiratory system can be thought of as being composed of 2 components, the pump and the load. The pump includes the respiratory muscles, the rib cage, and the anterior abdominal wall, and its function is to move air in and out of the lungs. The load on which that pump acts includes the airways and the lung parenchyma through which gas exchange occurs. The load is the actual respiratory tract, and it's divided anatomically into 2 main parts. The upper respiratory tract, which consists of the nose, the nasal cavity, and the pharynx, and then the lower respiratory tract, which consists of the larynx, the trachea, the bronchi, and the lungs. The pump that drives the load is made up of vital musculoskeletal support that includes the diaphragm, the rib cage with the tiny intercostal muscles between each rib, and then finally the accessory muscles. Now, technically, any muscle attached to the thoracic cage is considered an accessory muscles. It can act as an accessory muscle, but the primary ones that are used by our little ones are the sternocleidomastoid, the trapezius, the scalenes, and then the spinatus. So let's turn our focus then to the mechanical aspects of the pump because we actively see it grow and develop right in front of our eyes, and we can actively impact that growth and development through our early involvement with these infants. Musculoskeletal development is crucial to the functioning of the lungs, and so it really bears our attention. What often gets missed in the management of the preemie infant is the fact that the physical development of all 3 of these pump components is markedly affected by the NICU environment. It's often missed that we are growing a rib cage and we are entraining diaphragmatic and accessory muscle use patterns from day of life 1. So we want these to develop functionally, and so we need to look at numerous issues that impact this development. We need to know and we need to keep forefront in our minds what the end goal developmentally is for these components in order to support their functional development. So let's first think about the rib cage shape. Chest wall configuration changes significantly with age. The cross-sectional appearance of an infant's chest wall is more circular, and the ribs are oriented more parallel to the diaphragm, so there's less slope than in the adult. And because of this, then, in the infant, there is no outward displacement that's achieved by pulling that rib cage cephalid. The entire tidal volume for the infant has to be generated by the work of the diaphragm, which pushes the abdominal contents caudally to create a larger intrathoracic volume. So as we look at these 2 example x-rays, keep in mind that we're just looking at an anterior-posterior view. If we were also to look at a lateral view, we would see that the rib cage shape in proportion, it also changes anterior posteriorly, changing from a round or almost box shape to more of a broad oval shape. So this, along with the downward angling of the ribs as the infant gets older, makes lung expansion much more functional after growth. So if we think about the need for our little rib cage to attain a functional shape as it goes through ossification, and if we take into consideration what we know about the molding effects of gravitational forces on infants, then we can really start to see the need for somebody to be cognizant of the infant's positioning and the effects that habitual positioning can have on development of an optimally functioning rib cage. In addition to having a less advantageous functional shape, the chest wall of the infant is more cartilaginous and therefore it's much more compliant or collapsible than in the older child and the adult. Chest wall compliance decreases. In other words, the chest wall stiffens throughout gestation and then after birth. When the chest wall has a greater compliance than the lung, as is often the case in neonatal respiratory disorders, the chest wall can't keep its shape against the effort of spontaneous breathing. It collapses as the diaphragm pulls down and the lung then tries to inflate. Even with a normal inspiratory effort, the preterm newborn chest wall tends to collapse inward during inhalation. So in this situation, then, much of the muscular effort that's generated by the diaphragm is lost to chest wall distortion and does not contribute to expanding the lungs. So the highly compliant chest wall then makes inspiration more strenuous and inefficient for the already compromised infant diaphragm. Because of this inefficiency, then, infants have to adopt a breathing strategy to dynamically elevate their end expiratory lung volume. That's the amount of air that's left in the lungs at the end of exhalation. They have to elevate that above what is passively produced by the outward recoil of the rib cage and the inward recoil of the lung with expiration. So this strategy is necessary in order to maintain an adequate lung volume and to prevent airway closure that could happen because of reduced outward recoil of their highly compliant chest wall. So they achieve this by three mechanisms. A higher respiratory rate with insufficient time then to exhale to the elastic equilibrium volume level. Secondly, laryngeal adduction during exhalation so that they can increase the resistance to airflow. And then finally, maintenance of diaphragmatic muscle tone during expiration. Turning now then to the accessory muscles. At birth, they have not yet developed an optimal length-tension relationship to produce a motor force that's adequate to significantly move the chest wall or the head. It's not until about 3 to 6 months post-term that infants begin to develop the agonistic-antagonistic relationship of most upper extremity muscle groups. Extensor tone increases and the anterior chest wall significantly opens up. So the ribs are still horizontal at that point, and so the intercostals still are not functional. So the infant uses his upper anterior chest muscles to assist with ventilation. At about 6 to 12 months, the infant is in an upright position increasingly, and this posture then allows gravity and the developing abdominal muscles to start to pull and rotate those ribs downward, and thus that elongates the chest wall. So this downward rotation of the rib cage then allows for those intercostals to finally develop and come into play for breathing. Moving to the diaphragm, of course, has several functions: inspiration, swallowing and emesis, and then, of course, it provides a barrier between the thoracic and the abdominal cavities. The diaphragm can be broken down into two sections. There's the costal diaphragm and the crural diaphragm. The costal diaphragm is a thin domed sheet of muscle that's made up of radial array of muscle fibers that extend out from the ribs and then into a central tendon. The crural diaphragm is a thicker muscle that's more posterior, and it attaches to the vertebra surrounding the esophagus and the aorta. Both the costal and the crural muscles insert into the central tendon, which is located at the very top of the domed diaphragm. At resting lung volumes, the diaphragm is recessed into the thorax, and that creates an area of apposition or overlap between the rib cage and the muscular regions of the diaphragm. With contraction of the diaphragm during inspiration, then the central tendon and the abdominal organs are pulled caudally, while the rib cage is pulled in a cephalid direction. Because of the horizontal shape of the neonatal ribs, the diaphragm does not sit as high up into that rib cage. So there is a markedly reduced area of apposition between the chest wall and the diaphragm. The chest is virtually already expanded for the infant, with only downward space for that diaphragm to expand capacity into. So that really places the neonate at a mechanical disadvantage compared to the adult. When we look at the development of the diaphragm, we have to take into consideration the development of muscle fibers. Skeletal muscle, of course, comes in two major classifications. There's the red type 1 fibers and the white type 2 fibers. Those red type 1 muscle fibers, they have a high capacity for oxidative phosphorylation and or aerobic work, which requires oxygen. So they have a high myoglobin content, and myoglobin stores high levels of oxygen bound up as oxymyoglobin. Oxymyoglobin is what gives the type 1 muscle fiber its reddish color, much as oxyhemoglobin then does for arterial blood. The white type 2 muscle fibers, on the other hand, that muscle relies predominantly on glycolysis, which does not require oxygen for the energy that they to perform work. So it consequently has a low myoglobin and a high glycogen content, and so it appears white to the naked eye. The white type 2 fibers are the fast-acting fibers, but they're less capable of sustaining repeated contractions than the red fibers. In preterm infants, only 10% of the diaphragm is type 1 fiber, the type that is best fit for those sustained contractions. Beyond 2 years of age, those type 1 fibers increase to 55%. So the respiratory muscle of the infant then is much less capable of sustaining ventilatory efforts in the face of any increased work than that of the adult. So the diaphragm then is markedly underdeveloped for the neonate, and it acts less efficiently because of the highly compliant chest wall and a more horizontal insertion at the rib cage. It's also poorly equipped to sustain high workloads due to the lower numbers of fatigue-resistant type 1 muscle fibers in that first year of life. So here's a quick example of what we've just talked about. You can see the compliance of the chest wall as it's not able to stand up to the pressures that are generated by the work of breathing. While that descending diaphragm goes down, and so the chest wall sinks in retraction and retracts. So you'll be able to see the abdomen distend as its contents are pushed caudally by that descending diaphragm. So in looking then at our NICU infants, we really realize the numerous items that are attached to the infants, the positioning, and then the movement limitations that are imposed, and in some cases, the physical trauma that these treatments inflict. This can all have a huge effect on the infant's musculoskeletal and neurodevelopment, and also their physiologic stability. The principle of biotensegrity can help us understand the impact of everything that's attached to the infant and the positions that that infant is placed in. Biotensegrity is the principle of tensegrity as it applies to our physical makeup, our muscles, our bones, and our fascia. So here's a quick little hands-on explanation of biotensegrity in general.
So this is a tensegrity structure. It was my great good fortune to work and study with Buckminster Fuller early in my life before I became a body worker. And he was the fellow who developed the geometry. Kenneth Snelson, the artist, first started making these kinds of structures. What I'd like you to notice about these is that the dowels, the bones of this structure, if you will, are floating in space, and they are held in space by the balance of the elastics, the muscles and the fascia, the myofascia, if we were doing an analogy to the body. So these structures, we're not used to looking at structures like this. This is similar to a balloon, maybe. But otherwise, we're used to structures that are continuous compression, like houses. So we structured our body as if it were a continuous compression structure too. We think the head sits on the neck, and the head and the neck sit on the torso, and that it's like a stack of bricks all the way down to the ground. But in fact, the bones, well, at least we could consider it this way, the bones float inside the soft tissue. And when you start seeing the body this way, you see a lot of things. You see how the problem in the hip can really be founded in the arch, that the problem in this side of the neck is down at the bottom of the rib cage on the other side, because you start seeing how the interrelationships of things start working in the body. So Ida Rolf used to say, where you think it is, it ain't. And this tensegrity gives you a model where you can see, oh, if this pulls over here because the whole structure gives into it, the pain might be over here somewhere. And we're looking for ways of modeling this that would be predictive, so that we could say, okay, if you have this kind of problem, then we should look in specific places to help sort that. But this kind of model for the body really has a whole new way of thinking about ourselves that is not the usual muscles on the bones kind of model.
So the late John Chappell explained biotensegrity as it applies to our neonate quite well. He stated, once in full gravity, immediately after birth, the NICU infant carries with them a biotensegrity, a load throughout its entire body and its systems that will affect all systems, from the molecular level to the global synaptic functions. So we're going to move now to the respiratory developmental commonalities. There are numerous respiratory comorbidities seen in the NICU, and I wish we had time to cover each of these because they each do have their own unique impact. But there isn't time, so we're going to look at what commonalities there are in relation to these diagnoses, infant development, and then oral feeding. There are quite a few commonalities running across these diagnoses that can impact the infant's development. A very apparent common impact for us to see is oromotor and sensory impact. The face and the mouth receive a ton of sensory stimulation and manipulation. There are indwelling items such as ET tubes and OG tubes. There's tape. There can be CPAP interfaces and head and chin straps. There can also be excessive secretions that are stimulated by respiratory support and then repeatedly suctioned or cleaned by caregivers. There's common impact by nutrition, and this comes from several factors. These infants can have increased work of breathing, which consumes lots of calories and so makes weight gain very difficult for the infants. Also, dependence on supplemental oxygen or recovery from interventions or pathology often delays initiation of PO feeding. And so once PO feeding is initiated, then these little guys are often easily fatigued when faced with the aerobic activity of feeding. And then finally, integration of breathing with sucking and swallowing is often very difficult for them to master. Many times nurses and physicians may need to be reminded that these kiddos need some extra time and patience. They really must master breathing first. Another common thread among respiratory comorbidities is their impact on sleep. Some of these little ones experience many sleep disruptions due to various tests, procedures, exams, etc. Sleep can also be difficult for some of these little ones because of pain and discomfort, such as the case with pneumothorax or pleural effusion treatment. And then sometimes sleep is difficult because of a lack of consistent physical support for positioning maintenance. They fall out of comfortable positioning and then they're awakened and they struggle repeatedly to get back into flexion or a comfortable position. Lack of sleep can have a big impact on both brain development and on growth. Remember that REM is when brain wiring goes on, and quiet sleep is when proteins are synthesized and growth happens. So if we want these little ones to be neurologically mature enough to eat by mouth and physically big enough to handle the environment outside of their incubator, we really need to be assessing for these disturbances. They are important to our outcome goals for these infants, and nobody else on the medical team has such a vested interest as we do. Musculoskeletal impact is also a commonality with several of the respiratory comorbidities. It can come from multiple sources, and if we don't proactively patrol and address for these causes from day of life one, these infants can fall victim to the iatrogenic effects of their diagnosis. So this can impact them feeding for them both in the NICU and then even later on at home. Remember, these infants are building the foundation structurally and neurologically for their future development. Many of the respiratory diagnoses can predispose the infant to static positioning. Sometimes that's due to true medical necessity, due to lines or drains or ventilatory needs. But sometimes it is simply due to caregiving routines and practices that are caregiver-based and not infant-driven. So likewise, independent movement is often limited. Invasive lines, monitors, bandages, those can all limit movement and alter functional movement patterns. Also, sometimes then caregiving times are the only times an infant might be freed from swaddling or boundaries, and these brief periods are often not long enough for the infant to experience enough movement or movement pattern establishment, or even for fluid mobilization. Maladaptive breathing patterns are another commonality of many respiratory diagnoses. The most common maladaptions are scapular breathing and neck hyperextension, and neither of which are supportive for functional oral feeding. Scapular breathing is often used by older neonates in an attempt to increase the upward mobility of the rib cage so that they can increase tidal volume and forced residual capacity. Neck hyperextension then is often used in an attempt to increase chest wall expansion. And both of these strategies subject infants to increased tightening of the neck and the shoulder girdle musculature. Infants will typically respond very well to manual intervention via massage, gentle stretch, or even trigger point release. Finally, just about all of these respiratory diagnoses will impact the infant's interactions with their parents. If parents aren't interacting with their infant, then they're not building competence and confidence with their parenting skills. And that then can impact their abilities and comfort with learning to feed their infant. So special attention to adaptations that enhance interactions despite any physical or medical limitations is really needed in these cases. So what then can we do to set these little ones and their families up for success? There are actually several things that we can do long before PO feeding is even on the radar, starting from soon after birth. One early intervention that we can institute to help set our little ones up for success with PO feeding is mobilization and movement facilitation. Children are at the same risk for adverse outcomes from prolonged immobilization as adults, even more so for them because their immobilization then happens during critical periods of development. Among the proven benefits of mobilization and movement facilitation are that it may decrease sedation needs, may shorten any time on the vent, can assist with edema management, can assist with secretion mobilization, and it may assist with respiratory rate regulation. There was a 2012 study by Zimmerman and Barlow that looked at the impact of vestibular stimulation on breathing. And they found that when infants were held, given a pacifier, and received a series of vestibular stimuli, 15 minutes, 3 times a day for 10 days, the infants increased the respiratory rate in response to the vestibular stimulus. So they concluded that vestibular stimulation delivered to preterm infants prior to scheduled feeds effectively modulated the respiratory rate and reset the respiratory central pattern generator. In addition to this study, then, early studies from the 80s and 90s showed that rocking stimulation reduces the frequency of apneic spells and decreases the need for respiratory therapies. So if you think about all of the sensory inputs that NICU and PICU infants receive, vestibular stimulation is on the bottom of the frequency list. If you think about infants in utero, though, they really get an enormous amount of vestibular stimulation. Their moms are constantly moving around. If they're born prematurely, then that developmental stimulus all but stops. So there are various ways to provide mobilization and movement. The easiest and the best is through kangaroo care. The push through the Vermont Oxford Network's All Care is Brain Care initiative is for skin to skin holding to actually begin within 72 hours of birth and to be provided daily for extended periods of time. So we can also provide mobilization and movement facilitation through caregiving times through providing hands-on support and active or passive movement opportunities for the infants. In addition to mobilization and movement facilitation, there are also important habilitative strategies surrounding positioning of the infant that can set the infant up for success with oral feeding. Periods of neglected positioning can not only impact musculoskeletal development, but what many physicians and nurses don't realize is that it can also impact medical goals. And if medical goals are slow to be reached, then PO feeding will be delayed and even possibly irreversibly negatively impacted for the infant. So when we address positioning, it is important to realize that it needs to involve three components in order to be effective. First, there needs to be monitoring of the infant's positioning, not just between caregiving times, but also during caregiving itself and during procedures. Secondly, there needs to be education. Since optimal positioning is something that is necessary 24/7, every caregiver, whether they're professional or family, really needs to be knowledgeable and accountable. In order for everybody to be on the same page, then there has to be education. And then finally, assistance at the bedside during caregiving and procedures is really important. Supportive handling and positioning don't typically come easily for disciplines that are primarily procedure or task-based. So our presence and our assistance at the bedside with nursing and respiratory therapy then can help them learn to assess the infant's needs, attain and maintain optimal positioning, and then appreciate the difference that that optimal positioning can make for their patients. So as we talk about infant positioning, we need to keep in mind that the diaphragm is pinned down on all sides, and so it's very susceptible to torsion and pulling. It also has numerous very important structures passing through it that are subject to that torsion and pulling. The aortic hiatus allows the aorta, the azygos vein, and the thoracic duct to pass through. The esophageal hiatus allows the esophagus and the vagus nerve to pass through. And then the caval hiatus allows the inferior vena cava to pass through. So keep all of that handy in your head. Next, let's reflect on the intrinsic musculature layout. What's important here is to visualize the impact all of the muscles below the diaphragm can have on the diaphragm and the structures that run through it that we just talked about when those muscles are pulled to their maximum length and tension by the legs or the hips being in extension. So add to that what might happen with these muscles if those lower extremities are turned in the opposite direction of the torso. So as we talk about habilitative positioning, picture those two diaphragms. So let's first look at supportive prone positioning. And prone, as we know, is the most supportive positioning for breathing. If the knees are fully tucked and the hips are flexed, then it offers the optimal length tension ratio for that little diaphragm. It also allows gravity to assist that diaphragm, and it allows for posterior chest wall excursion if the shoulders are nice and rounded and the arms are dropped down to open up the back. An elevated support surface under the chest provides chest stability through weight bearing as well. So it's important to realize that small infants really must have a proning support in place under their chest to raise the torso enough to allow for shoulder flexion and optimal head-neck positioning. The optimal positioning for the head is to keep that head turned less than or equal to 45 degrees from midline. So when we do that, that maintains an optimal airway. When the head is fully turned 90 degrees, so that that little chin is on the shoulder, the top half of the pharynx is effectively closed, and the trachea and the larynx are then under torsion. Keeping that head turned less than 45 degrees from midline also then decreases the risk for dolichocephaly, scapulocephaly, because it prevents that infant from laying on his entire lateral skull. If you look at each of the 5 infant positions that are possible, you have supine, right side lying, left side lying, prone with the head to the right, prone with the head to the left. If you look at those 5 positions, you'll see that 4 of them typically can involve that infant laying on the complete side of his head. And it's that pancake flipping gravity pull from side to side that shapes the head. So bringing the infant off of his ears by supporting his head to be turned no more than 45 degrees from midline when they're in prone, that gets 3 of those 5 positions off the side of the head. So that can help immensely. So sideline tolerance for infants with respiratory comorbidities can at times be very difficult. Infants may tolerate one side more easily than the other, and so staff may tend to favor positioning the infant on that more favorable side in order to avoid having to increase the infant's FiO2. So sometimes infants will be equally intolerant to both sides, though. And that doesn't mean necessarily that they should not be placed on their sides. Alternating right and left is very important. It supports symmetrical ribcage development that we talked about, but it also is important for atelectasis prevention and also for edema prevention. Often then, sideline tolerance can be facilitated by providing solid bedding support against the infant's spine. This will provide stabilization of the spinal rib insertions. It will also support the infant to maintain his positioning so that he doesn't fall out of it. Another facilitative technique is to support the head. Facilitative technique is to support the head in neutral flexion to prevent stimulation of back arching. And then finally, just like we talked about with prone positioning, the hips should be flexed with the knees tucked to the tummy. That's what gives that optimal length tension ratio for the diaphragm. Supine, as we know, is the least supportive for breathing. Gravitational impact on breathing is the greatest in supine. And so we really have to pay close attention to flexion maintenance when the infants are in supine. Since those upper extremities and lower extremities easily fall victim to gravity, they're going to need full contact support from the bedding. Under the triceps also to keep those little hands up and accessible for grasping and calming and coming to the face for normalization. And against the bottom, the infant's bottom and the bottoms of the feet to keep those hips and the knees in that flexed position. And it is also important to avoid use of shoulder rolls. These put pressure on the occiput and they promote neck hyperextension. Stress relief is also a very important habilitative consideration. Chronic exposure to stress can affect an infant's future oral feeding because brain development is influenced by early life stress exposure. Early stress exposure has been found to affect brain structure and behavior, motor function, and stress reactivity. While neurogenesis is generally complete by the end of the second trimester, new synapses are still forming and synaptic pruning is still going on into that early and middle childhood. So synaptogenesis and synaptic pruning are sensitive to environmental influences. So our individualized interventions to relieve stress can actually then have a mediating effect. So as we all know, one of the best stress relievers is skin-to-skin holding, but parents tend to underestimate their abilities for helping their infant manage stress. Sometimes the key to getting them to provide skin-to-skin holding more regularly is simply to schedule a skin-to-skin session so that you can be there to help them prepare their infant, to transfer their infant, and then to help them learn to interpret their infant's behavior. Oftentimes, parents have misconceptions that their infant is uncomfortable, or they may see some discomfort signs and not know how to remedy them. And oftentimes, too, the infant's nurse is not able to stay close by once the infant has been transferred to the parent. And so there's no one present during those first 10 to 15 minutes of that infant settling in to help the parent kind of sort through what they're seeing and how they should respond. So there are, of course, added pre-feeding bonuses to skin holding too. The infant and the mother get really comfortable with each other through skin to skin. The infant can also nuzzle at the breast, and then the mother's milk supply, of course, is boosted by that close contact with her infant. Massage is another really great tool for relieving stress. It does this on a couple of fronts. It induces the release of oxytocin, which calms the nervous system. It also helps to decrease that scapular breathing pattern. As we talked about, scapular breathing is often used with the older neonate in an attempt to increase that upward mobility of the rib cage so that they can increase their tidal volume and forced residual capacity. So this can then lead to significant hypertonicity in that shoulder girdle. So, and of course, when we can see how this could negatively impact oral feeding through both postural and respiratory impingement. So a common secondary benefit to massage is that once that muscle tone is normalized, the breathing often becomes much more efficient, and so the infant's FiO2 requirement may decrease. Sometimes this is for a couple of hours following the session and sometimes longer. But each time, they're able to be freed from the effects of their maladaptive breathing pattern, they get to experience efficient breathing. And so they eventually will let go of that scapular pattern. So the sooner the infant improves his breathing, the sooner they can move on to PO feeding. Of course, going hand in hand then with reduction of shoulder girdle muscle tone is reduced neck hyperextension. So that helps to normalize the airway, but it also brings that mouth back down to where the infant can actually reach it for self-comforting and also for some sensory normalization in preparation for oral feeding. One very important note for our SLPs. Massage is not just limited to OT and PT intervention. Development of correct breathing patterns and correct posture is tantamount to transitioning to PO feeding, and it takes a whole team to make sure that these kiddos make that transition. So all three disciplines really need to be hands-on with positioning and relaxing and realigning. For NICU, the Neonatal Touch and Massage Certification Program is very appropriate. It takes into consideration the uniqueness of the preemie and their goals, the medical status, the brain maturation, the developmental status, the parent stress. The program's approach, the techniques, and the education are unique to NICU infants. For therapists, it goes into great depth with anatomy and additional therapeutic intervention, not just the bonding and nurturing aspect of massage. For the term in older infants, the World Institute of Nurturing Communication provides the CME certification, Certified Infant Massage Instructor certification. It's more bonding and nurturing based. There are 2 additional levels of CME certification being offered now. They have introduced their 3rd level certification as a NICU focus certification. Levels 1 and 2 are a prerequisite. They review the current trends in environmental science, behavioral cues of NICU babies, touch adaptations, premature skin, and supporting the family through the process. It teaches how to remedy the NICU's toxic insults through the use of containment holds and comforting touch. I am neonatal touch and massage certified. I am not CME certified, so I can't specifically speak to the in-depth contents of its training. I can tell you that I do highly recommend bringing infant massage into your practice repertoire, though. So the final habilitative area that we're going to touch on in this section is oral aversion prevention. And as we last discussed with massage, bringing that head down into neutral flexion allows for a very important prevention mechanism, and that's the ability for the infant to get his hands to his face and mouth. This allows the infant to experience positive touch to an area that is overwhelmed by all sorts of unnatural sensory input, some of it painful, some of it not painful, but none of it normal, and it's way in excess of what that brain expects to be receiving. Another mechanism for oral aversion prevention is taste of EBM or formula. And once again, in utero, the infant would have been exposed to the flavor of his mother's breast milk through the flavonoids present in the amniotic fluid. So allowing him to enjoy the taste of expressed breast milk can actually calm him and provide some positive counteractive sensory input. Another important part of oral aversion prevention is to regularly take note of the equipment that might contribute to oral aversion, either because of the type of interface used or the application techniques that are used. So look at what's available on the market. Is there something better that might be considered by the team? For our intubated infants, are the nurses and the respiratory therapists regularly checking to make sure that the tube is not taped or pulled into in a position that would put pressure on the alveolar ridge or the corner of the mouth? Would use of a neobar be better for the infant than taping the ET tube directly to the lip? What type of suction catheters are being used? Are they soft enough? For infants on CPAP, is the CPAP interface providing any negative sensory input by the way it's fitting the infant? Is the type of CPAP being used the most comfortable? Does it allow for easy exhalation through the nose, or does its pressure cause the infant's exhalation to exit the mouth and stimulate excessive secretions, which necessitates frequent oral suctioning or mouth wiping? Some types of CPAP have negative effects more so on some infants. Procedures are another area that need monitoring and review. Suctioning frequency should be considered. Is suctioning done PRN or is it on a regular schedule? PRN is, of course, the desirable option here. Some units, though, may perform suction on a schedule because of the respiratory therapist's workflow habits. They're running sometimes all over the unit or sometimes all over the hospital. And so naturally, in these situations, they may want to schedule their visits. So how can that be changed to benefit the infant? Can communication between nursing and respiratory about necessity and timing be revamped to make suction PRN and keep it to a minimum? Also, how is suction done? Do all the professional caregivers providing suctioning understand that how suction is done can make a major impact on the infant's PO future? Are they very diligent about keeping all types of suctioning, oral, nasal, or ET tube, to a minimum? Are they using very gentle and slow movements with the suction catheter? Are they being careful to try and not induce a gag reflex? As far as taping, we need to look at the nasogastric tube, the ET tube, and the orogastric tube. We need to look at how often these are being removed and reapplied. Is there a standard procedure to be followed by everybody, or does each professional have his or her own method? Once again, does everybody really appreciate the impact that their procedural style can have on that infant's PO feeding future? With ET tube taping, how is the infant being supported to remain calm during the procedure? During ET tube taping, caregivers are focused like hawks on that ET tube to prevent its movement. And because of this, any positional support that's needed by the infant must usually come from swaddling or a bunting. So that takes pre-planning. Having a third person at the bedside during retaping is usually not possible. So these types of equipment and procedural reviews can only be done if you have established a good professional relationship with the nurses and the respiratory therapy staff. So groundwork here is very key. So we talked a little bit about habilitative strategies for use during the pre-feeding stages, and now we're going to look at a couple of tools that can help with some of the tough decisions surrounding initiation of oral feedings with our fragile respiratory infants. Infants with chronic lung disease, by definition, are still requiring some form of FiO2 support at 36 weeks gestation or postmenstrual age. So beginning PO feeding takes special consideration and precaution with these infants. There's been a lot of discussion over the past decade over the safety of PO feeding infants on CPAP. CPAP is meant to stent the airway open, and the airway does need to close for swallowing safety. So our logic tells us, and then also the experience of any of us who have experienced CPAP tells us, that eating on CPAP may not be a safe endeavor. A systematic review by Canning et al. In 2021 actually looked at the pediatric population research involving infants and children who were on nasal CPAP or high flow nasal cannula who were then orally feeding. Their primary outcomes included full or partial oral feeding and oropharyngeal aspiration. Their secondary outcomes examined the adverse events, including clinical signs of aspiration, aspiration pneumonia, and then deterioration in respiratory status. There were 16 studies that actually qualified and were included in the review for data extraction. They were, however, unable to do any meta-analysis because the respiratory modes and the cohorts of the 16 studies were not comparable. 11 of the studies reported on adverse events. Oral feeding safety was predominantly based on retrospective data from chart entries and clinical signs, with only one study actually using an instrumental swallowing evaluation to determine aspiration status. So they concluded that there simply was insufficient evidence to conclude whether commencing oral feeding while on nasal CPAP or high flow nasal cannula facilitates transition to full oral feeding without adverse effects, including oropharyngeal aspiration. So the bottom line was that further research is required to determine the safety and the efficacy of oral feeding on CPAP and high flow nasal cannula for infants and children. We just still don't have an answer. The Ferrara et al. Study in 2017 was the one study that the Canning Systematic Review found that actually looked at aspiration status with an instrumental swallow. They looked at infants who were still on CPAP at greater than or equal to 34 weeks postmenstrual age and were taking over 50% of required feeding volumes by bottle feeding. So these infants were fed on a CPAP of 5 with a mean FiO2 of 25% during videofluoroscopic swallowing studies to determine whether they were aspirating when they're being fed. And the researchers became concerned then when each of the first 7 patients demonstrated abnormalities of swallowing function that indicated varying degrees of aspiration. So they took each patient off of CPAP in the radiology suite and they replaced it with 1 liter per minute nasal cannula to achieve acceptable oxygen saturations, and they repeated the study. The results of the 2 swallow studies then showed remarkable differences in the risk to the patient, and as such, then the recruitment of further patients was stopped because of concerns of safety, and they gave a firm recommendation of avoiding feeding while on CPAP. So the Ferrara study gives us some great ammunition for the concern that CPAP might increase the risk of aspiration, or at least for laryngeal penetration with PO feeding. But has still not been enough research to definitively say that all infants should or should not be fed PO while on CPAP. So there are many factors to take into consideration for this. There are different types of CPAP. And of course, there are different types of babies. A couple of things to consider when we look at risk are the size and the postmenstrual age of the infant. CPAP of, say, 5 on an 1,800 gram infant is typically going to be different than CPAP of 5 on a 3,600 gram infant. The larger infant has the musculoskeletal strength and development to be able to posture himself better, and also to forcefully exhale against the PEEP that's being generated. Previous PO experience of the infant also comes into play. Is this an infant that is totally new to PO feeding, or has he had some previous practice? Infants that have PO feeding skills already in their repertoire might be able to navigate suck, swallowing, breathing with low flow CPAP. The type of nasal interface and the amount of inherent leaking is also a consideration. Some prongs are tighter than others in the nares. The more leaking, the easier to breathe against and divert the flow during swallowing. And then finally, what type of CPAP is being delivered? One very important thing to note with the Ferrara study is that they used a ram cannula and a Draeger vent. So they were delivering a continuous CPAP. With constant flow, there's much greater resistance to try to exhale against. And so the work of breathing can be greater. With a variable flow, say with the fluidic flip or infant flow driver, those infants can exhale against that easier, and therefore there is a little bit less work of breathing. The inherent difficulty with decisions regarding feeding on CPAP then is that there are just so many variables to consider. There's no way to measure exactly how much flow or pressure the infant is experiencing. And even if we could, each infant's ability to manage eating in the presence of that flow and pressure can be greatly different. So there are a couple of tools that can help us with the management of initiating and advancing PO feedings with infants receiving high flow respiratory support. And one for infants on high flow nasal cannula called the risk assessment for oral feeding on high flow nasal cannula, and then one that can be used with infants on high flow nasal cannula or CPAP called eating in sync. And I have the rundown of the risk assessment for oral feeding on high flow nasal cannula for you on this slide, and then we're going to speak to it as we look at the assessment itself. So feeding on high flow nasal cannula can pose similar risks to feeding on CPAP when the leader flow is high. High flow nasal cannula can deliver CPAP at high enough flows, and so it really needs to be carefully evaluated. The risk assessment for oral feeding on high flow nasal cannula was created by University of Florida Health Shands Hospital, and it's an adaptation of Wolf and Glass's teachings. It takes into consideration some very important factors that I just mentioned a few minutes ago, and it gives them a risk-adjusted score. It looks at the postmenstrual age, the previous experience with PO feeding, the O2 flow rate, the FiO2 requirement as an indication of the infant's fragility or risk, and then also the comorbidities and the medical complexity of the infant. Then it suggests what degree of oral feeding might be appropriate based on the total score that's obtained. The fewer points accrued, the less at risk the infant is believed to be. And so the more oral feeding introduction he is felt to be able to handle. So this is a great tool to consider using for these complex kiddos. When you have neos or nursing really pushing to feed these infants, this gives them somewhere on that continuum of oral feeding acquisition to actually begin working and feeling like they are accomplishing it. Another great tool was developed by a group in Alberta, Canada, and they've published a very structured incremental method for introducing PO feeding to infants who are supported via high flow nasal cannula or CPAP, and it's called Eating in Sync. And as we did with the previous tool, we'll step away from this overview slide and look at the tool itself. So the Eating in Sync protocol is an algorithm format that's very familiar to and frequently used by physicians and nurses. And it progresses the infant very slowly. First with non-nutritive sucking, either with a pacifier or at an emptied breast, then with drops on a pacifier or short time on the breast, then with restricted time and amount from a bottle or restricted time from the breast. Then the infant is allowed to slowly do more as his behavior and his performance indicate. And if he's ever has difficulty with a step, he is taken back to the previous step. One thing of note here is that the Calgary group uses the infant flow fluidic flip type of CPAP. So that's the type of CPAP that allows for a bit easier diversion of the airflow during exhalation. Also of note is that they have not looked, as far as I know, at aspiration in their population. It would really be great if they could do some instrumental swallow studies and see if they find something different than the Ferrara study did. In the systematic review that by canning that I talked about, the delivery device was never mentioned. The decreased work of breathing and the ability to interrupt that flow for exhalation may actually make a little bit of a difference by allowing additional time and more normalized pressures for swallowing. So, when considering then initiation or an advancement of oral feedings for our infants on increased respiratory support, there's just so much more research that's needed in the area to guide us. Until we have it, it is really important that we use our knowledge of anatomy and physiology of the aerodigestive tract, our knowledge of the current evidence base, and then our knowledge of each infant's competencies and sensitivities and risks. We also need, though, to take into consideration where our NICU team is in their knowledge, their comfort, and their competence with feeding this fragile population, because all of these factors really play a role in how an infant might be able to handle oral feeding while he's receiving an increased level of respiratory support. So we've covered quite a bit in this short hour. A little anatomy and physiology, a little development, and a little habilitation. And my hope is that it gave food for thought and stimulation for additional discovery. As Henry Ford said, coming together is the beginning, keeping together is progress, and working together is success. We are truly blessed to be able to work with these tiny little humans and their families. And I want to thank you so much for joining us today.